I know you discussed this in 224, but it is something that does end up in critical care, so we're going to discuss it again. The rule of nines are on a page page 1019. The London-Browder method is a little bit more specific, and it's on page 20. You just need to remember that rule of nines. It's a whole lot easier. For a superficial or first-degree burn, you'll have erythema and pain for 48 to 72 hours. If nobody's ever had a sunburn, anybody who's had a sunburn will know that's about right. And this tends to resolve in 7 to 10 days. A partial thickness burn, or a second-degree burn, involves the upper third of the dermis. It's mottled. It'll be wet and weeping. You may have a bulla that's formed. Don't puncture it. It's painful. It's very sensitive to the air. So again, don't puncture the blister. Therefore, air won't get at it. And you'll have increased permeability, which causes those blisters. Tends to heal in 7 to 21 days. If it's deep, it takes 4 to 6 weeks. And there's a picture on page 1020 that shows partial thickness burn. A deep dermal partial thickness, so again, a second-degree burn, doesn't have blisters. Blisters are rare. It has red patchy white areas. The wounds will turn yellow over time. It takes 6 weeks to heal. It can cause contractures, but it doesn't usually cause a lot of scarring. And there's a picture for this on page 1022. A full thickness burn, or third-degree burn, is one that is painless because you burn the nerve endings. But this does require a skin graft. There's a picture on page 1021 and 1022 for the burns. Your initial burn management, there's a table on page 1024. You can use the Parkland formula if you want to, which says it's 4 liters, but the average is 2 to 4 milliliters per kilogram per percentage burn of rigorous lactate. And this is in whole numbers. So if you had 30% of your body burned, you'd multiply the total by 30. Half of the total needs to be given in the first 8 hours from the time of the burn. The next fourth is over the second 8 hours, and the last fourth is over the third 8 hours that you're going to give. 100% oxygen initially, if it's a major burn or an inhalation type burn. May require a ventilator, particularly if it's an inhalation type burn. And an eschorotomy if it starts to cause a compartment syndrome. There's a picture on page 1023 that can look at that. Burn shock can occur if more than 35% of the total body surface area has been burned. You'll get hypovolemic shock and tissue trauma, causing fluids to third space. Increasing permeability puts the fluid and the protein into the tissues, causing edema. And this starts to increase in the first 2 hours after the injury. Renal management, Foley, intake and output. And to be adequate, the adult must have an output of at least 1/2 to 1 milliliter per kilogram per hour. Minimum 30 to 50 milliliters an hour. If it's a child, they must have at least 1 milliliter per kilogram per hour out. GI system, if there's more than 20% of the total body surface area burned, they will develop a paralytic ileus. So they'll need an NG tube in and H2 blockers. Pain control is done with morphine. Even if you have a third-degree burn, the area around is second degree, and that's going to hurt a whole lot. And if you don't believe me, have you ever had a sunburn? And does it hurt? And the answer is yes. Think second degree will be much worse, so you need to have something for pain. Morphine works really well as a PCA. Compartment syndrome is always a risk because the eschar doesn't allow the tissues to expand. So you need to check your peripheral pulses to make sure they don't get compartment syndrome. And if they do, you'll do have the physician do an eschorotomy, or they'll cut that eschar, or do a fasciotomy and cut the fascia. You want their heart rate less than 120, their CVP less than 12, and their wedge or occlusive pressure less than 18. They may develop an ineffective breathing pattern due to a full thickness burn of the chest, and to treat that you need to remove the eschar, that thick leathery scar. The labs that are done, you'll have an H&H. Your electrolytes, they'll show hyperkalemia because of the damaged cells. metabolic acidosis, and a decrease in renal function. So you need to correct the acidosis. Your BUN will start to go up. Your creatinine may or may not. Hopefully your creatinine will not, and it'll just show that your patient's severely dehydrated. Your urinalysis will be done, and your drug screen and your alcohol screen to make sure that that's not part of the cause of the problem. Hypokalemia can also occur because of the fluid loss and or hemodilution, and they may develop some nausea, vomiting, and diarrhea, so you need to treat the cause. The hyponatremia is also due to the fluid loss, the nausea, vomiting, diarrhea, and the NG drainage. You need to assess your patient at least every 4 to 8 hours and again treat the cause. They will have a chest x-ray and electrocardiogram, and if they have an inhalation injury, blood gases. They need to get tetanus toxoid if they have more than 10% of their total body surface area injured. An inhalation injury or carbon monoxide can cause carbon monoxide poisoning. And keep in mind that carbon monoxide has a 300 times more affinity for your hemoglobin than your oxygen does. And on room air, the half-life of carbon monoxide is 4 hours. On 40% O2, it's 2 hours, and on 100% O2, it's 40 to 60 minutes. And in a hyperbaric unit, it's 30 minutes. So that's why they put people with inhalation injuries in hyperbaric units. Your normal amount of carbon monoxide is less than 2%. If you smoke, 10 to 15%, but you may complain of a headache. 15 to 40%, you're going to have some central nervous system dysfunction, and 40 to 60%, you're going to be unresponsive. Symptoms are headache, dizziness, nausea, vomiting, dyspnea, and confusion. Early, in other words, your first symptoms are changing your level of consciousness, lightheadedness, and tachycardia. Late symptoms are unresponsive and respiratory failure. Treatment is the 100% oxygen. I had a really good friend whose husband decided to work on his pickup truck in the garage in the middle of winter, and she thought she better check on him after about half an hour. And she found him passed out underneath the engine because he had the car running and the garage shut up tighter than a drum. He did go into the hyperbaric unit and was left with no residual. The sad thing is this man was a state patrolman and should have known a whole lot better. You can also use a non-rebreather mask or an endotracheal tube at 100% until the amount of carbon monoxide attached to the hemoglobin is less than 10 to 15%. If they have an upper airway obstruction in the first 24 to 72 hours, trach them. This may lead to a chemical pneumonitis, leading to acute respiratory distress syndrome within a few days. And you'll know that because their pH will start to climb, their PaCO2 will start to drop, the respiratory rate will go up, and they will become hypoxic. This is treated with PEEP. Upper airway injury, the maximum injury will occur within 24 hours. Treatment is to intubate, elevate the head of the bed 30 degrees, give them bronchodilators, cough and deep breathe, put them on a vent or put in a trach. The lower airway damage, you observe them for 24 to 48 hours and give them symptomatic treatment. Now, non-thermal burns can also occur. And non-thermal burns can be from chemicals or electrical burns. Chemical burns, you want to flush them with water. If it's an alkali burn of the eye, you're going to flush that for hours. We're talking 3, 4, 5 hours, continuous flushing. Tar burns are removed with petroleum distillates because tar is a type of petroleum product. Electrical burns, keep in mind that electricity travels to the ground, so your burns here can cause severe acid-base alterations and rhabdomyolysis. You don't use the burn fluid replacement formula for electrical burns. The intake is adjusted for their output if myoglobin is present. You need at least 100 to 150 milliliters an hour out in adults, 2 milliliters per kilogram per hour in children. Treatment is forced alkalotic diuresis. Every organ is involved if more than 20% of the total body surface area is burned. You will be administering bicarb and diuretics to force that alkalotic diuresis. There are 3 phases to burn management. The resuscitative or shock phase lasts until the patient starts to diurese. Your goal is to maintain vital organ function and perfusion. Inhalation injury is the most common cause of death. In acute care, this starts with the diuresis to the closure of the wound. The cause of the death here is due to infection and sepsis, and then you have rehab. So, in the shock phase, treatment, fluid resuscitation, Ringer's lactate in the first 24 to 36 hours. After 24 hours, capillary leakage stops, and you're going to administer colloids like sulforalbumin, dextran, or fresh frozen plasma. You'll give 0.3 to 1 milliliter per kilogram per percent total body surface area that's burned to decrease the edema. And you'll possibly administer hypertonic saline to do that. And you'll stop the saline when your sodium reaches 160. You want to prevent infection as an imperative part of this, but keep in mind you're going to have insensible fluid loss. Normally we lose about 500 milliliters a day. With a burn, we can lose an additional 300 to 3,000 milliliters a day. They'll have a triple lumen catheter to do so they can do a CVP. They're at risk for hypothermia. You want to keep the temperature between 99.6 and 101 Fahrenheit. They rarely put in a pulmonary artery catheter. Lab work is done only as required because of the increased risk for infection. Sulfadiazine or Silvadene is used for wound care, and if the white blood cell decreases to 1,500 to 2,000 for 12 hours, you'll stop the Silvadene because this is something we don't want to occur. Transition to the hypermetabolic state. You'll have in the inflammatory phase that lasts from injury to 4 days, an increase in your granulocytes and your fibroblasts, causing an increase in the amount of collagen that's produced. The proliferative phase lasts from day 4 to day 20. During this time, we'll have an increase in collagen. Epithelial cells will migrate, closing the wound, and you'll have epithelialization and wound contraction. And the maturation phase occurs from day 20 to 1 year after the injury, and this is what causes your scar formation. Wound care, you're going to have daily cleansing using saline or hydrotherapy, a little bit of force there because your hydrotherapy puts your patient at risk for hypothermia. Pain control is important. You need to use your PCA. You want to protect against infection, so you need to spray the tables and chairs to make sure that there's not a problem there. You'll have wound debridement of that eschar. You need to cut away the eschar because otherwise it can cause compartment syndrome. You're going to use wet to dry or wet to wet dressings to debride that area. May use some proteolytic enzymes to do that. Wound care, that's listed on page 1033 to 1035. You're going to cover that wound with a skin substitute such as polyurethane film, biosynthetic dressing, or hydrocolloidal dressing. Some of those are called Opsite, Duoderm, BioBrain, Tegaderm, or Acticoat that you might do. Topical antibiotics that might be used are listed on page 1034, and the ideal properties of a skin substitute are listed on page 1035. Your topical antibiotics, Silvadene, you need to change that dressing daily, and it is bactericidal. Silver nitrate, you need to keep the dressing moist, so you need to re-moisten it every 2 to 4 hours. It is antimicrobial. Sulfamylon is bacteriostatic. It penetrates the eschar. It's very painful, so pre-medicate your patient. Change your dressing twice a day, and it can cause acidosis. Bacitracin ointment is your open treatment only, and so it puts you at risk for ototoxicity and nephrotoxicity with this, so you have to use some care with this. Burn closure, you close 20% of the wound at a time, or you have a surgery of 2 hours duration, whichever occurs first. Therefore, they're going to have surgery about every 2 to 3 days. There are different types of grafts, and there's a table on page 1036. An autograft is preferred. This is from the patient themselves, and that figures on page 1036. A homograft is from a cadaver. A xenograft is from another species, usually a pig. And then you've got your synthetic skin, which is CEA, or cultured epithelial autograft, that can be used. Nursing diagnosis based on, or treatment based on your nursing diagnosis for altered tissue perfusion. Renal, you're going to have increase in myoglobin, so your urine's going to be a dark port wine color. You need massive amounts of IV fluids and diuretics, every hour output, specific gravity, bicarb. Remove the Foley as soon as possible because they could go into acute renal failure. Cerebral, you want to assess them with a Glasgow Coma scale and maintain an adequate cerebral perfusion pressure. You may be giving them mannitol IV, and you're going to be doing their hourly output for at least 72 hours. Peripheral is due to third spacing, altered tissue perfusion, so they're at risk for compartment syndrome. So you need to check color, warmth, movement, and peripheral pulses every hour. They get no pillow under their knees. They need to elevate the legs. You need to do range of motion. And you need to assess for intravascular integrity every hour for 48 hours, checking the 6 Ps, and those are pulselessness, pallor, pain, paresthesias, paralysis, and poikilothermy, which is an elevated temperature or a decreased temperature. That's the 6P. The loss of the pulse in and of itself is a late sign. And if it lasts for 12 to 24 hours, you're going to have irreversible nerve injury. Treatment for this is a fasciotomy. The GI system, ileus is common. You want to assess bowel sounds every 2 to 4 hours. They're at risk for stress ulcer or curling ulcer. You need to keep their pH of the stomach at 5. Check for a GI bleed. Insert an NG tube if necessary. Do a nursing diagnosis. Your nursing diagnoses are listed on page 1040, by the way. Hypothermia may be a problem, so you can use heat shields, lamps, fluid warmers. You need to keep their temperature 99.6 to 101. Impaired gas exchange, put them on a ventilator and add PEEP. Ineffective airway clearance, and a tracheal tube or tracheostomy tube. Ineffective breathing pattern, do an eschorotomy. Anxiety and fear, guided imagery, education, medications that might be useful. Acute pain, again, medications, opioids or NSAIDs, some Tylenol sometimes even. Cover the wound, because it's when the air gets to the wound that it hurts. Chronic pain, they may have paresthesias that last over a year. Nutrition, less than body requirements because their BMR will increase by 40 to 100%. And it will do that for a long time. So they need to increase their caloric requirement by 2 to 20 times. They need to increase their protein requirement to 2 to 4 times the normal of 0.8 per kilogram. They need to increase their intake of the zinc and copper and manganese and the other trace elements, because they'll need all that for healing. They'll have impaired physical mobility, so that can they may have splints or require range of motion. Burn care takes special people and lots of patients and a lot of aseptic care. It takes special nurses to be burn nurses, in my opinion. That finishes this lecture. Oh no, I forgot. Fluid volume deficit. May have insensible fluid loss of 300 to 3,000 milliliters per day, so they need fluids. And of course, risk for infection, so you need to be aseptic technique and antibiotics. And that should finish